Can you hear me, Dr. Abdusalam? Dr. Abdusalam?
Okay. Assalamu alaikum wa rahmatullah.
Yes, the screen is yours. I have already introduced you. Maybe you can't hear me because the headset. Now we can hear you. You can start.
تسمع فيا؟
Yes.
كيف في الصوت بس؟
Yes, the screen is yours, my friend. You can start.
Okay. بسم الله الرحمن الرحيم. Thank you, Dr. Ali, for inviting me to be one of the speakers among this dental meeting. My pleasure today to share with you my decision-making of treating peri-implant soft tissue recession, and in which cases we have to do a soft tissue graft and hide and treat this complication, and in other cases it is better to remove the implant and start from zero. So I think we start our story and our technique of treating such cases by doing simple cases of placing implant in aesthetic zone. And as we know, placing implant in aesthetic zone is not easy and it's difficult. You have to consider a lot of many factors. So start our journey with placing the bone graft, doing some Cori technique, taking the photos, discuss with the patient different treatment options and different modalities for treating such complication. And we using our kits from development, and our protocol is completely changing nowadays from surgical point of view and from prosthetic point of view. We're going to do mucogingival flap, opening the flap from the buccal side, trying to maintain the soft tissue in place, try to optimize the bone and soft tissue both. In previous, we concentrating on the bone rather than on the soft tissue, but nowadays we're concentrating on both bone and soft tissue. So because this is the balance of static implant dentistry, restoring the implants is not easy, I said, but it is not difficult in the same time. You have to consider to place your implant in 3D implant position. You have to keep in mind that the aesthetic tissue reconstruction is needed, as well the prosthetic management. So nowadays the patient will not accept this result of placing implant restoring upper central incisor, because the previous dentist placed the implant following the socket of the tooth and placing the implant on the buccal side, doing some pressure on the labial bone. Despite the thickness of the keratinized gingiva, the patient lose this buccal bone and try to show part of the abutment and part from the crown, and unequal gingival position between between implant and adjacent tooth. So we're going to show you now today to how we can treat those patients and how we can take this patient from this level to another level of optimizing the soft tissue, optimizing the zenith with the adjacent tooth. Okay. At the same time, how we can do that? By controlling the soft tissue volume, optimizing the bone, controlling the soft tissue volume to give the patient the best aesthetic result. And as we know, critically thinking, the prevention is better than reconstruction, better to prevent these complications from happening, better to prevent these complications from happening rather than reconstruction. How we can prevent that? By respect the implant position, 3D implant positioning, restoring the implant prosthetically driven, not surgically driven. Don't follow the bone, don't follow the surgical skills. You have to follow prosthetically driven implant position, respecting the distance between the multiple implant. If you're going to place multiple implant, respect the soft tissue thickness, respect the soft tissue height. If you consider all of these factors, you can prevent such complications from happening, because soft tissue around implant, not unlike teeth, actually soft tissue around implant like scar, a lot of fibrous tissue, minimum blood supply, and most of those complications occur in the zone that connecting the soft tissue with the gingival margin, which is called transition zone. These complications can be reported as papilla loss, as mucosal recession and discoloration and soft tissue volume deficiency. So today we're going to try to show you how we can manage those complications. And I said the factors that most commonly associated with such complications is the principal factor is placing the implant in buccal position. This is the most common cause of peri-implant soft tissue recession, placing either the implant shoulder or implant platform or completely placing the implant outside the housing of the bone in buccal position. The other reason, using the wider implant, placing to restoring upper central using 5 millimeter, 6 millimeter to restoring upper central. This is too big, too large to placing the implant in a static zone. The ideal diameter actually to restoring the upper central is 3.5, 3.7, 3.8, not more than. Even we have socket, a large socket, you place your implant in palatal position, keep this gap, fill this gap with bone, try to hide in the soft tissue, try to hide in the shadow of the implant and abutment by placing the bone, placing the connective tissue graft. Because in some cases, the patient, not all the cases is perfect. In some cases, the patient has thin gingival phenotype, inadequate carotid gingiva. So you're going to manage those principles and those factors before you consider to placing implant. Some patient has a bony dehiscence, some patient has pathological problems. You have to deal all of these situations and try to optimize the soft tissue as well, the bone. Okay, so the other factor you have to bear in mind that the decision making is mainly based on many factors. First, you have to consider and you have to keep in mind, this is the most common, is the integrity of interproximal soft tissue. And in this case, the aesthetic failed case, we're gonna see in this presentation, is it has metallic exposure with loss of interdental papilla or without metallic exposure. Because in some cases, our problem only in the thickness of the soft tissue. The soft tissue level is perfect, the papilla is perfect, but we have slight or concavity on the buccal side, so you have to deal with that concavity by adding soft tissue, even without you elevating the flap by tunneling technique or Vista technique or another technique. While in complicated cases, when we have loss of interproximal papillae and when we have loss of interproximal bone, this is the most difficult job to restore in case of peri-implant soft tissue recession. So the other point is, as I said, the interproximal soft tissue integrity, because in some cases you can do soft tissue graft in the presence of the crown, as we can see in the left side. While in other cases, when we have a problem in the interproximal soft tissue, either resorption or recession, it's better to remove the crown, remove the abutment, and place the cover screw, and let the soft tissue to heal. You have to wait minimum 2 months for the soft tissue to mature and heal and decay, and deal with that site as edentulous site, and start from zero by splitting the soft tissue, elevating the papilla, mesial and distal, split thickness, surgical, anatomical, and try to chronally advance this flap and treat this complication, as we can see in the cases later. The other factors you have to bear in mind, this is very critical factor, the position of the implant head. Is it inside the imaginary line connecting the gingival margin of 2 adjacent teeth or outside this imaginary line? Because if the implant head is outside imaginary line, this is class 4. This is class 4 as according to the Zucchelli classification. And this is most likely either to do submerged implant technique, or better to remove that implant. The other fact that the prosthetic options, is it possible to do prosthetic management, or the angulation is too big buccal, too much buccally? We cannot restore it by even with the abutment that available in the market. The other factor you have to bear in mind, the interproximal, in case of multiple implant, interproximal distance or interdental distance. This is very important, because this we're going to support the interproximal soft tissue and we're going to support the interdental papillae. Sometimes in some cases we can, like in this case, it is better to remove one of those implants rather than keeping both implant, because there is no room for the bone to form between those two implants, and there is no bone to support the interproximal papilla. The other factor you have to bear in mind, the blood supply and the contamination, because the problem with the implant, not like teeth, the problem with the implant, we are dealing with metallic surface and not easy to do decontamination of this metallic surface in case of peri-implantitis. So today I will not talk about the peri-implantitis. All of my cases are implant free from any type of peri-implantitis, not contaminated. There is no any contamination of the implant surface. Okay. The other factor, the minimum bone thickness available over those implants, because in some cases when the implant is placed in the buccal position and trying to open full thickness flap, actually you will disturb the connective tissue adhesion over the implant. So if the implant position outside the bone housing, it is recommended to open split thickness flap, keep the attachment over the implant threads to receive the connective tissue graft. If the implant head inside the bone housing and we're going to place connective tissue graft, even if you open full thickness flap, it will not be a big problem. But if the implant head is outside the housing and trying to open a full thickness flap, actually you will disturb the connective tissue adhesion over the implant, and you will end up with another story, another complication, which is difficult to solve. The other factor, the harvesting of the connective tissue graft, in some cases it's better to harvest. Today I will talk only about the aesthetic zone. So no free gingival graft is indicated to treat such complication in aesthetic zone. You can use the free gingival graft to improve the keratinization, deepening the vestibule, removing the muscle attachment, placing the keratinization, improve the keratinization around the implant in posterior, not functional non-aesthetic zone. But in aesthetic zone, it's recommended to harvest the connective tissue graft that derived from free gingival graft, because we believe that the best quality of connective tissue graft is from free gingival graft, free from any adenoids and glandular tissue. Okay, the final point, you have to consider the patient expectation and satisfaction, because in some patient, when the patient has low smile line, the patient can accept this pink porcelain, while in other patient, if the patient has high smile line, will not accept this final result. So in some cases, implant removal become indicated, and there is no right and wrong according to, when we're going to manage such cases, because the limitations, many limitations in the literature, one of them biological limitation, as I said, the vascularity and the decontamination, and is it osseointegrated implant or not? And the scientific support is based mainly on clinical experience. Very few clinical studies has been published. Most of the clinical studies are isolated reports and few clinical support. One of the most famous studies that recently published by Professor Zucchelli is the classification, how we can classify the soft tissue dehiscence around single implant site. And also he write the recommendations for each class, which surgical technique we're gonna to do with each class. And he recommend and he emphasized the use of autogenous gold standard connective tissue in treating such cases. So this is the evaluation protocol. When you face a case of aesthetic implant failure, you have to do clinical examination, gingival probing margin. You have to evaluate first the gingival margin position according to the adjacent tooth. You have to evaluate the papilla height. Is it subclass 1, subclass 2, subclass T? You have to evaluate the gingival biotime, because the target, our target, from adding the soft tissue graft to reach 2 millimeter thickness of soft tissue, to be able to hide this transparency and prevent further recurrence. You have to also evaluate the soft tissue quality. You have to do probing around the implant to exclude the presence of peri-implantitis and bone dehiscence. And you have to do radiographic examination. Radiographic examination include 2D and 3D. 2D to evaluate the interproximal bone, and 3D to evaluate the position of the implant. Is it inside or outside the bone housing? Finally, you have to evaluate the prosthetic options and the possibility of correction. Is it possible to correct this prosthetic fault or not? So what is the best technique for restoring those complications or treating those complications? Either we start with dental prosthesis by adding some pink porcelain. Some patient can accept this pink porcelain, or by reconstruction of the soft tissue and hard tissue, or by permanent or temporary implant submergence, or surgical repositioning of the implant, or finally, you have to explant this implant and remove this implant in some cases. Many techniques has reported in the literature, starting from chronally advanced flap to the Vesta technique to the submerged root technique. I will go to the most of these techniques. So this is one of the article reported by the Dentistry now and his colleague Stephen Chu, by restoring and treating the aesthetic failed implant around 2 lateral incisor, bilateral lateral incisor, by triple technique, adding the bone graft, the membrane, the connective tissue. This is the only, not the only actually, but this is one of the studies of using the bone graft to treating such case. We're gonna to treat those complications with only soft tissue. I don't use any type of bone graft to treat such complication. So my protocol, I follow a Zucchelli protocol, that novel surgical prosthetic approach of removing the crown. This is the study of by Zucchelli, novel surgical technique by Zucchelli. You have to go some fast. This is the surgical protocol of Zucchelli. Start with removing the prosthetic, removing the crown, in some cases changing the abutment to the surgical one with narrow and a thin one, and give the chance and wait, and give the chance for the soft tissue to creep. As we can see, this is the first case of using prosthetic surgical approach, because I believe that with this approach, we can solve most of those complications of aesthetic failure. So first, I take the index for the crown. Second, I remove the crown out. And finally, I evaluate the degree of buccal placement by placing the screwdriver. After that, deliver acrylic, temporary acrylic crown, short, away from the gum, 0.5 to 1 millimeter. You have to open the embrasures slightly, try to change the contact point in every visit, give the chance for the soft tissue to creep before any surgical intervention. This is the same case before and after we do the SD to determine the amount of soft tissue graft we needed to treat such complication. And we move from this beginning pink porcelain to this case. So we move from this case to another triangle. We start with the orange one and end up with the green one. Now you can see the thickness and the height. With this step, very simple step, just changing the crown, changing the abutment, open the embrasures, keep the crown away from the gingiva. This will give the chance for the interdental papillae, mesial and distal, to creep and form and improve in thickness and improve in height, because this will give you the support for the coronally advanced flap, for the surgical papilla. If you don't have good interproximal soft tissue, your flap will not stay in position, and the flap dehiscence and failure is reported. That's why we're going to start with this soft tissue dehiscence away from the crown. And you can see after 2 months, the improvement of the interdental papilla, mesial and distal, and the improvement of the marginal gingiva. This is the same case before and after. This is the same case before and after. And this is the same case. Another case, just first, I will show you the effectiveness of prosthetic surgical approach. And with this technique, how you can improve the soft tissue, improve the quality of soft tissue before any surgical intervention. Surgery is easy, but you have to prepare the bed. You have to prepare the papillae, mesial and distal before any surgical intervention. Same case before and after delivering the Maryland prosthesis. Same case before and after just changing the crown, removing the crown, the old crown, make it short, changing the abutment. Sometimes I keep the abutment, just removing the finish line when the abutment is inside the housing. But if the abutment is outside the housing, you have to change it with another angle, narrow, thin abutment to give the chance for the soft tissue to creep. Okay, the same protocol. Let's start with the first case of changing the crown. This is the first case. This is the CBCT showing implant shoulder in the buccal position. This is the smile of the patient. I removed all the crown, changing the abutment, place short acrylic crown, cement retained, change the contact point slightly, give the chance for the soft tissue to creep, and we can see this is the concavity, and this is before and after, and this is the day of surgery. Now, in the day of surgery, as we can see, now we have big, large, wide interproximal soft tissue. You can do your incision now at the base of the interproximal papilla, mesial and distal, adding two vertical releasing incision, mesial and distal, the conventional trapezoidal flap of single incision even around the teeth, the same. Try to split the papilla. If this papilla is thin or not prepared well pre-surgically, how you can do your surgery now? Difficult. It's difficult. You will end up with laceration, with the tearing, with the flap dehiscence, and you finally will say, "Oh, chronally advanced flap is not working in my hand." No, not the problem in the chronally advanced flap. The problem in the preparation of the case. You didn't prepare the case well to receive this type of intervention, this type of flap. So split thickness, no periosteo elevator, all are split thickness even over the implant, all split thickness. Try to keep the attachment over the implant threads. Try to do deep split and superficial split to be able to move your flap in coronal direction passively without any tension. Okay, after that you harvest the connective tissue, suture it at the base of the interdental papilla, mesial and distal, and coronally advance the flap in coronal direction. And this is the result after 2 weeks. We keep the suture until 2 weeks, sometimes 3 weeks. And this is the result after 3 months and waiting for more maturation of the soft tissue. And this is the lateral view. Professor Zuccheli has 5 years outcome after root coverage of coronally advanced flap. Another case of 2 implants placing beside each other, but we are lucky in this case. Why we are lucky? Because the distance between the 2 implants is adequate. We can build the interproximal soft tissue. Even with bone resorption, we can improve the base and the thickness of the interdental papilla, and after that we can do some conditioning in the healing stage to end up with very good aesthetic result. So removing the crown, placing acrylic one short, open the embrasures, just gingival flap, envelope gingival flap, splitting the papilla, removing the finish line, adding the connective tissue, and coronally advance the flap and suture the flap in coronal direction. This is the DSD. We can see we start with this and end up, there is no shadow now. We hide in the shadow, improving the interproximal, improving the height, trying to place short crown on the left side to give the chance for the soft tissue to creep, and the right side needs some conditioning to optimize the aesthetic result. We did intraoral scan. Dr. Khairi Al-Azraq, he's my friend, prosthodontic, working with me in Abdusalam Center in Tripoli. He did the prosthetic part, did intraoral scan. He delivered 2 crowns from Al-Khduri lab. Technician Abdullah Al-Khduri, he is also working with us in Abdusalam Center. Another case of aesthetically failed implant of bilateral lateral. We are lucky also because the implant position mesodistally is good, despite the buccal position and despite the soft tissue thickness and shadow of the implant bilateral. We follow CPCT, we follow the same protocol, removing the crown, changing the abutment, open split thickness flap around multiple teeth, like we modified the coronal advanced flap described by Zuccheli at DeSantis. placing the connective tissue graft, move the flap coronally and suture it in coronal direction with many type of suture technique, with sling suture, with simple interrupted vertical mattress, and place the short temporary crown and try to condition this case. After that, try to change this crown sequentially, give the chance for the soft tissue to creep step by step. This is after 3 months. You can see now the concavity before and after. We're treating the buccal concavity, hiding the shadow, and this is the final result. This is the final result after 6 months. Another case of bilateral lateral, Dr. Al-Hussein now, he's working with me, prosthodontic, working with me in Al-Hussein Dental Clinic in Tripoli. You have to mention the names of the other colleagues that working with me. He delivered also the 2 temporary crown after soft tissue improvement. As we can see, I'm placing the soft tissue graft over the two implants, mesial and distal, and he delivered the final crowns, and this is the post-operative occlusal view. Another technique of implant submergence. Implant submergence actually described by Lay in 2010, and another article described by Dentistry now and 7.2 in 2013. It's indicated in non-superficial implant, not to buccal, either to do it temporary, to give the chance for the soft tissue to move and mature over the implant, or do it permanent. I will start with permanent submergence, and I will say why in this case do permanent submergence for this implant. Why? Because this implant is placed in buccal position, severely buccally angulated. The adjacent teeth all are cored, so need to do static crown lengthening and placing the crowns over those implants. So I discussed with the patient different treatment options. According to the Zucchelli classification, this is a class 4 because the implant heads outside the bone, outside the line, and subclass P because we have some of the some of the interdentobellar recession. So Professor Zucchelli, in his article, he recommends to do soft tissue platform augmentation technique and to do temporary implant submergence to give that chance for the soft tissue to creep after 2, 3, 4, 5, 6 months, depending on the case. You're going to do surgical coronally advanced flap by adding horizontal and vertical soft tissue augmentation. But in this case, because we have an obstacle that the prosthetic, the abutment angulation is too buccal, the abutment angulation we didn't have in the market, so we're going to do implant removal. But the final decision to do was to do permanent implant submergence. This is the DSD of the patient, and do DSD to determine the amount of crown lengthening, mesial and distal, and to determine the amount of soft tissue graft over that implant. I opened 2 times of 2 flap, full thickness flap over the teeth to do osteectomy and osteoplasty, static crown lengthening, not exceeding the mucogingival junction, and open split thickness flap over the implant, trying to preserve the connective tissue adhesion over the implant to place the connective tissue graft. Try to do deep split, superficial split to be able to move the flap coronally. And thanks again for the interproximal soft tissue. You have to do split thickness papilla, mesial and distal. This is the anatomical papilla to receive the surgical papilla. You have to do deep palatal until the palatal halves. So we're going to suture the graft in buccal and do connective tissue bancho technique for the occlusal one, using the healing abutment to hold the connective tissue graft and move the flap coronally and suture the flap in coronal direction. And this is the healing after 2 weeks, and this is the healing after 1 month. After 1 month, I removing the healing abutment, I place the cover screw, and I start the prosthetic phase. This is very critical, very important phase, because in this phase, you're gonna to manipulate the soft tissue as you design your crown. So don't go to the final crown immediately. You have to deliver the first set of temporary to give that soft tissue a chance to mature. After 2-3 months, deliver the second set of temporary to give the chance for the soft tissue to manipulate and try to optimize the soft tissue as the adjacent, and after 6 months, when you optimizing the zenith with the adjacent teeth, you can deliver the final crown. And this is the same case. After 1 month, we did some adjustment with the laser to adjust the zenith. Why not? Because you adjust the bone when you open the flap, because you do coronally advance the flap. Sometimes the zenith is not 100% optimizing. You can take scalpel just or laser or any type of device and adjust the zenith and deliver the second set of temporary. This is before and after, and this is after delivering the first set of temporary. Now you can see the pontic side development. You can see the tissue conditioning at the implant side and the tissue conditioning on the teeth side. This is the second set of temporary intraoral scan, and this is the second set of temporary trying to optimizing more the zenith of the teeth, open the embryogenes, give the chance for the interproximal tissue to mature, because this is very critical after 2, 3, 4, 5, 6 months from the surgery. And we'll end up with this final result. This is the patient smile, and this is before and after occlusal view, and this is before and after frontal view, trying to optimizing the zenith, the interproximal space, try to give the patient final smile. And this is the final smile of the patient before and after. And this is collecting the all cases, photos of the case before and after patient smile, and the final patient smile. And this is the whole case from beginning to the first set of the temporary, to the second set of the temporary, to the final prosthesis. And we have also 1 year follow-up. We are lucky of this patient because the patient come back to us and we have 1 year follow-up and did CBCT to be sure that the implant is silent. There is no any signs of infection. There is no any signs of secondary infections or any changes. This is the 1 year follow-up showing stability of the soft tissue over the implant as well over the teeth. And this is the occlusal view showing the stability of the implant, also of the soft tissue over the implant. And this is the patient smile. This is a critical case because the patient has high smile line. We try to optimize the final aesthetic. This is another case of temporary implant submergence. This is another example of temporary implant submergence. We're removing the crown. This is the same case. We follow the technique described by Dentistry now on 7th June 2013, implant decoronation. I remove the crown, remove the abutment, place the cover screw, place Maryland bridge, try to change the Maryland bridge sequentially, give the chance for the soft tissue to creep and form. And after 3-4 months, I start the surgical technique by opening split thickness flap over the implant, full thickness flap over the teeth, placing the graft, do coronally advanced flap, and this is the result after 2 weeks.
Abdusalam, can you hear me?
The result after 2 months from surgery. So we start with this and end up with that. We start with this kind of recession, and when we end up with optimizing the gingival zenith and gingival thickness and hide the implant shadow. This is another case of temporary implant submergence. You can see the disaster of the aesthetic placing the implant, trying to do another from another dentist, try to do soft tissue graft, but he keep the case more difficult. Why more difficult? Because the problem not only on the buccal side, the big problem in the interproximal bone loss and interproximal papilla loss. So in this case, it is recommended, don't do any kind of surgery in presence of the crown. Don't do any kind of surgery in presence of the abutment. You have to remove the crown, remove the abutment, place the cover screw. Don't lift the patient without any temporary prosthesis. You have to place the temporary prosthesis near from the soft tissue and try to modify this temporary to give the chance for the soft tissue to creep. This is the CPCT. And this is the same patient after 1 week. And this is the same patient who delivered the temporary acrylic Maryland bridge and try to open the embryogenes. Try to open the embrasures. This is the first before we do anything. This is after 1 month, and this is after 3 months, and this is after 6 months. We keep the Maryland bridge until 6 months. Why? Because the case is disaster. We try to optimize the interproximal, try to get the more, as much as we can of interproximal soft tissue, because this is will give you the support at the day of surgery. And this is after 6 months. This is at the day of surgery. Okay? This is the day of surgery. If you don't do implant submergence, you will not able to do this split thickness. Implant submergence giving you the adequate thickness of soft tissue to do this type of incision. So measuring the defect, try to splitting the papilla, mesial and distal, do split thickness over the implant. Try to keep the attachment, try to keep your blade parallel to the bone, beginning parallel to the surface of the outer surface of the tissue. After that, keep your blade parallel to the bone to do split thickness over the. Okay, you can see the attachment now. This is the soft, the white one. This is the soft tissue, and there is some bone particle because the previous dentist tried to manage this complication by adding some bone. After elevating the flap, sorry, yeah. After elevating the flap, we try to do deep split and superficial split. Superficial split by removing the muscle attachment from the flap, and deep split by removing the muscle from the periosteum. And open the palatal flap beveled connective tissue platform technique. This is called connective tissue platform technique, described by Professor Zucchelli at 2013, to treat such a defect and to be able to place your graft over the connective tissue bed. We try to de-epithelialize this platform. Now you can see the thickness of the interproximal soft tissue. Okay, I have to go fast, sorry. After that, the suturing of the graft. Suturing of the graft, harvesting of the graft, and suturing of the graft in coronal and on labial, in vertical and on buccal position. Why on vertical? To give the support for interproximal soft tissue. We have interproximal bone loss. It is not indicated to place a bone because there is no place to add some bone particles. But there is a place to improve the soft tissue height by placing the connective tissue graft platform over the platform first, sutured with 70 BDGA vicryl suture, and suture another graft on the buccal side. Okay, this is the suturing of the buccal. After finishing the suturing of the graft on the coronal, and this is the height and drive it from its connective. And this is the final. Finally, you have to do coronally advanced flap, which is passively move it. Start to suture the vertical by taking periosteal sutures at the end of the flap from inferior for both sides. Try to hold your flap coronal. At the end of suturing, you will see that your flap is moved coronally without any tension. Passively to suture it on coronal direction, in crestal direction. So start with vertical releasing incision, 6-0 Prolene suture or 6-0 vicryl suture, the same, no difference. And try to do two periosteal sutures at the bottom of the two vertical, and complete the vertical suturing on both sides. And keep the crystal suture at the end. Okay, we're gonna to adapt the surgical papilla that's formed because thank is for pre-surgical prosthetic management that give you this papilla that now you able to split it and suture it with the palatal one. If we don't do any prosthetic management for this case, you will end up with maybe another kind of complication that's make the scenario more difficult and more difficult to manage. Okay. Okay, this is the final result, 2 weeks after suturing, and this is after 3 weeks from suturing. Now you can see the stability. You can see the soft tissue interproximally between the central and lateral. This is our target, to improve the interproximal papilla mesial and distal and try to hide the soft tissue. And this is, we apply the periocan gel in most of the cases, hyaluronic acid gel, to improve and accelerate the healing. And this is before and after. This is before the intervention, and this is 2 months from the intervention, and try to deliver finally the final crown after some time. And this is the healing of the palate by adding some hyaluronic acid to improve the healing. And finally, in some cases, it is indicated to do dentogingival prosthesis, screw retained crown on screw retained suprastructures in case of extremely large defects, or in some cases where the patient can accept this final result. This is not my case, but the patient came to me for extraction of lower 8. When I see this kind of prosthesis, I ask the patient, are you happy from this prosthesis? He looked to me and he said to me, yes, why not? This is good. The color of the pink porcelain, like the gingiva, I like it. Okay, I said to him, enjoy. So it's indicated to do hybrid prosthesis when we facing a deficiency, large deficiency in the bone and soft tissue. This is all in 4 case, restoring the missing maxillary teeth. And in some cases, we're going to do explantation and non-osseointegrated implant and flapless, and when there is decontamination, and trying to do reconstruction, and the story will start from 0. Okay? You have to keep in mind, and you have to think biologically in which cases you have to save, in which cases you have to remove. Critical decision making, you have to consider the integrity of the interproximal soft tissue, the degree of buccal angulation of the implant. Is it possible to correct it prosthetically or not? Presence or absence of contamination, and implant depth. Is it superficial or is it deep? Number of implants, distance between the implants, and possible prosthetic different solutions, and try to optimize all of these and try to take in consideration all of these factors. And finally, let's summarize and take home message and I think with prosthetic surgical approach, actually we can solve most of those complications of aesthetically failing implant, and future studies are needed to compare and ascertain the more long-term outcomes. Thank you for Dr. Ali for inviting me for this meeting. Thank you for my team working with me in Salam Center in Musrata here, Dr. Omar, Dr. Ali, Dr. Hanan. Thank you for Salam Center in Tripoli, Dr. Muhammad Shawish, giving the chance and opportunity to do to do and to optimize our team, Dr. Khairi, Dr. Hussein, Dr. Firas, Dr. Mena'em, Dr. Muhammad, a lot of doctors working with me either during preparation of the case, or helping me during the surgery, or helping me prosthetically after delivering the final prosthesis. Thank you for him. معلش لو نسيت حد ما سميتاش، آسف يعني من الستريس بتاع المحاضرة، لكن نشكر الجميع. أو thank you Dr. Ali for this presentation, and thank you very much.
Thank you very much, Dr. Abdusalam, for your nice presentation. I'm sure that everybody enjoyed it. And see you soon, Dr. Abdusalam. Thank you.
Thank you. Thank you, Dr. Ali. Audience, or there is no chance to answer the questions?
I think there is one question. Okay.
Yeah.
I don't know. Dr. Iman from Tunisia asked about one-piece implant compressive. What about your opinion?
Dr. Ali?
She asked about
Yeah.
one-piece implant compressive.
Okay.
I shared the comment in the screen. Yeah.
Okay. Actually, I am not the one. I answered this question because I don't have any experience actually with the single piece implant to restore in such cases. But I think one of the most complication reported in the literature with single piece